Welcome back, everyone, to Part 8 of our 20-part Dental Coding Masterclass. Now, if you were with us for Part 7, you know we absolutely conquered the Palmer notation and FDI two-digit systems. Today, we're taking the next critical step in this explainer. We're going to translate clinical oral health, literally the physical conditions of the mouth, into the standardized language of CDT coding. As medical coders, billers, and revenue cycle pros, mastering these diagnostic terms is exactly what allows us to establish medical necessity in charts and operative reports. So, ever wonder how your dentist actually turns that routine checkup into a perfectly formatted, standardized bill? Well, let's dive into this and demystify the administrative side of dentistry. I know it might seem like magic when a clinical exam turns into a flawless claim, but it's actually a highly structured process. And today, we're proving that accurate billing absolutely starts with understanding the physical tooth itself. Because let's face it, you simply cannot code what you don't anatomically understand. Here's our roadmap for today's explainer. We'll start inside a tooth's anatomy, then look at common terms and abbreviations, move into the CDT coding categories, break down billing for dental x-rays, and finally, wrap things up with oral hygiene and preventive care. All right, Section 1. Inside a tooth's anatomy, the biological foundation. We really have to ground our coding knowledge in the tangible anatomy of the tooth, because these physical structures directly dictate the procedures performed. Knowing your anatomy ensures you don't accidentally code a surface-level filling as a deep root procedure. As you can see here, we have the visible crown. That's the part sitting above the gum line. And below it is the hidden root, firmly embedded in the jawbone. Our billing codes map directly to these specific zones. What's really interesting here is understanding that when we code for surface-level decay or defects, we're dealing with the enamel. The enamel is that hard outer layer protecting your tooth from damage. It's actually the hardest substance in the human body, which is pretty amazing. So, when you see a procedure code for a simple restoration or filling, the dentist is primarily repairing damage to this tough outer shield.
But moving deeper, we find the dentin and the pulp. Dentin is located just under the enamel. It's softer, makes up the bulk of the tooth, and it carries these tiny nerve signals. Deeper still is the pulp, the innermost chamber containing the nerves and blood vessels that actually nourish the tooth. So the crucial takeaway for us is that when a procedure like root canal therapy is performed, the dentist is bypassing that dentin to treat this highly sensitive, life-giving pulp.
Now, the tooth doesn't just float around in the mouth, right? It needs support. We have the cementum, which is a thin layer covering the root to attach it to the jaw, and the periodontal ligament, which acts as this incredible shock absorber when you chew, keeping the whole tooth stable. Understanding these supporting structures is exactly what builds our foundation for periodontics, an entire branch of dentistry and coding focused on treating these areas when they become diseased.
That brings us to Section 2, Common Terms and Abbreviations. Let's talk clinical shorthand. Listen, medical coders and billers must be completely fluent in the clinical shorthand used in patient charts. If you can't read the shorthand, you can't accurately bill the procedure. It is absolutely essential to distinguish between what the dentist finds, which is your diagnosis, and what the dentist actually does, which is the treatment. Diagnosis describes the condition, like decay or gingivitis. Treatment describes the action taken, like an extraction or a filling. Mixing these two up is a fast track to claim denials.
Let's look at the diagnostic side first. You're going to frequently see CA for caries. That's tooth decay caused by bacteria. Compare that to AB for abrasion, which is non-carious structural damage often caused by mechanical friction like aggressive brushing. Knowing the difference between bacterial caries and mechanical abrasion is absolutely crucial for your ICD-10-CM coding and getting those pre-authorizations approved. You'll also see E/D for enamel defect, GI1 through GI3 for varying stages of gingivitis, PD1 through PD4 for periodontal disease stages, and ROT for a rotated tooth. These diagnostic abbreviations are what establish medical necessity in the chart. They prove exactly why a specific treatment had to be performed and billed. Now, once that diagnosis is established, you'll see these treatment abbreviations. RCT stands for root canal therapy, again, treating that dental pulp we talked about. RC is a composite restoration, or your standard filling. X is for a tooth extraction. You might also spot OHI for oral hygiene instructions given to the patient, NB for nerve block, and the term edentulous, which simply means a patient without teeth. These terms directly translate into the procedural codes we submit for reimbursement. Moving on to Section 3, the CDT coding categories. Standardized numbers.
So, let's transition from that clinical shorthand to the actual standardized numbering system known as CDT coding. The CDT manual is beautifully organized by category blocks. Preventative cleanings and sealants live in the D1000 to D1999 block. Restorative procedures, like your fillings and crowns, are D2000 to D2999. Endodontics, like root canals, are D3000 to D3099. And periodontics, treating those supporting gums and bone, are D4000 to D4999. This categorical chunking makes navigating the manual so much easier. For example, if you see the abbreviation RCT in a chart, you immediately know you're looking in that 3000 block for endodontics. Let's apply this to a real-world scenario in Section 4, Billing for Dental X-rays.
Diagnostic imaging is literally the foundation of preventative care. X-rays allow dentists to see what the naked eye just can't. One of the most common codes for this is D0210, which stands for an intraoral complete series of radiographic images. But here's the major catch for billers. This is typically only covered by insurance once every 3 years. So the crucial point regarding a full-mouth series is knowing your frequency limits, because billing code D0210 too often is going to quickly result in a denial and a very unhappy patient.
Then we have bite wing X-rays, which are incredibly specific. According to the guidelines, bite wings are meant to find lesions that are hidden from a clinical visual examination, such as when a lesion is hidden by an adjacent tooth. This explains perfectly why bite wing X-rays are an absolute necessity for detecting interproximal decay, meaning decay between the teeth that the dentist simply cannot see with the naked eye. They also help estimate exactly how deep that lesion is. When billing for bite wings, specificity is everything. You don't just use a generic code. Depending on the number of films taken to get that clear view between the teeth, you're going to select from this specific family of codes. D0270 is for a single film, D0272 is for 2 films, and D0274 is for 4 films. These can often be billed separately, or in addition to other specific diagnostic codes, always with the primary goal of detecting decay.
Finally, let's turn to Section 5, Oral Hygiene and Preventive Care, Keeping Disease Away.
We've talked a lot about finding disease and treating disease, but let's explore how we code for the prevention of disease, which keeps patients healthy and significantly reduces long-term healthcare costs. In the D1000 and D4000 blocks, you'll see 2 very different types of cleanings. And let me tell you, mixing them up is a huge error. It's incredibly important to note the difference here. Prophylaxis is a standard, professional cleaning to remove plaque above the gum line. It's routine maintenance. On the other hand, scaling and root planing is a deep cleaning procedure to remove hardened calculus and tartar from below the gum line. Prophylaxis is purely preventative, while scaling and root planing is a deeper, periodontic treatment required when real gum disease is present.
And hey, education is a billable service. When a dental professional provides individualized, one-on-one home care instruction, like proper brushing and flossing techniques, dietary recommendations, or showing a patient how to use those little interdental brushes, code D1330 ensures that this vital educational time is properly documented. Furthermore, this code can often be billed alongside other codes like exams or standard cleanings, such as D1110 or D0150. So, pulling it all together, accurate coding translates clinical care into standardized data. It ensures both proper patient tracking and correct reimbursement. Understanding this flow, from a physical tooth structure like the pulp or the enamel, to a diagnostic abbreviation like CA for caries to prove medical necessity, and finally to a CDT code in the appropriate numerical category, is exactly what empowers you to succeed in medical administration. And that is a wrap for Part 8. In Part 9, we're going to dive even deeper into procedural terms and some of the more complex clinical abbreviations you'll find in dental records like PRR and deep scaling. So, with this foundation set, which dental coding category will you master next as you navigate the business of healthcare? Thank you so much for joining me. Make sure to like, subscribe, leave any questions you have down in the comments, and follow the playlist to continue to decode healthcare with Harshal.